Welcome, everyone. It is a pleasure to welcome you to the closing keynote of this Congress, approaching the end of the Congress. The keynote is titled Financing UHC 2030 and the Health Systems Recovery. And there is a reason why we left it for the last, because across the past 2 days, we have heard about the many aspects of the accessibility, quality, and per se safety of the care, and of many issues and challenges patients or healthcare workers or other health stakeholders work around day to day. We heard about the challenges. We also heard many new ideas, innovative ways of how we can improve things, how we can do better. But then, as much as this sounds as a long wish list, many of those claims or requests or ideas are very legitimate to every patient, and they really speak about what everyone would want any place to have as a dignity, as a decency, and as a good healthcare and quality of life. But then one question, at least to me, and I hope we stayed with all of you across the 2 days, how are we going to afford it? And can we find ways to learn from the current pandemic, or how to really strengthen our health systems, how to make them more resilient, and yet at the same time make them better and safer? And it was very difficult indeed to find a person, an economist, that would be able to answer these questions. And we were very privileged and honored that Joe Kutzin has accepted the invitation. We hoped that we would have welcomed him in April in the face-to-face Congress, but we are glad that we have you here digitally. So Joe, before I pass the floor to you, I just want to give a brief introduction. So Joe Kutzin is really a global economist with an experience, to name just a few, in Africa, in Asia, Europe, US, Caribbeans, and so on. And he has been really, truly supporting patients and universal health coverage and the patient-centered healthcare. And I can say this from a personal experience, because the country I come from, if they didn't listen to Joe's advice many years back, we would have now been in the spiral of losing the universal health coverage. And really, I personally thank you for that, Joe, because it was a great thing that you've done. And I'm grateful that our ministers actually listened to your advice. So without much ado, I would like to pass the floor on to you on whether we can afford all of those items on the wish list, and whether we have learned something from the pandemic, how we can make the systems recover faster and become more resilient. Over to you.
Great. Thanks, Neta. Thanks for that, and your very kind words and your difficult questions as well, which are not easy. I think by now we should know that you don't turn to economists for answers, right? But just to kind of review some of the questions. But what I will try to do is think through in a way how, what are some of the key messages that we know in terms of how to approach this very challenging era that we're going towards with health financing, with UHC, and so on. And what lessons perhaps can we take from even the early responses in COVID, or at least what are the key issues that we have to take into account. So with that, I'll start, and hopefully by the end, there'll be some answers for this. I want to start by really talking about UHC itself, and one of the principles we have and how we think about policy and financing is that it's critical to try and reach some understanding and agreement, ideally, on what it is you're trying to achieve before we can start talking about, what's the best way of getting there, right? And this is perhaps more critical now than ever when we think about what universal health coverage means as a concept. And as I say, it's a normative concept. It's not purely describing something. The definition that we have used in WHO is as written here, that all people and communities are able to get the services they need, services of good quality, and without fear of the financial consequences of that. So these are really not, and sometimes you hear this expression of implementing UHC. UHC is not something to implement. Countries need to implement health system reforms in order to make progress on these objectives, okay? So that's a critical issue, because if you say something is just a UHC scheme, the next reasonable question is to say, well, yes, what is it? Is it something you're doing in human resources? Is it something you're doing in financing, ideally together, reforming service delivery and so forth? And underneath it, this idea that in effect, you've got these, in this definition, are goals about equity in service use, of quality, and of financial protection. But they're grounded in a core value, and especially in the expression, all people. And I try to use a little math. We sometimes joke that in order to keep our credentials as economists, we have to have at least one equation in every presentation. This is not so much an equation, but it means that we say sometimes universal means universal. All people means all people. And so if we don't have this, and without this kind of foundation, then we might be talking about health financing or health system reform, but we're not talking about those things for UHC, okay? So what I'm going to talk about is really about what are the lessons in terms of what we want to achieve in terms of universal health coverage. Now, there's many ways of showing it. There's also, you know, kind of thinking through, in a sense, that if we accept those goals and that value foundation, some of the implications are that coverage is a right and not just an employee benefit. And a lot of the history, in a way, of public policy on health coverage going back to 19th century Germany started with the logic of coverage as an employee benefit, you know, under the traditional social health insurance arrangement. And that was largely the approach in higher income countries up until about World War II. And it was really after that that the idea of universal coverage came to mind, where really everyone should get the services. I think one of the issues and problems for low and middle income countries is that a lot of the choices that were made early on in the 60s and 70s, often with the advice, unfortunately, from international agencies, was kind of replicating the model that had taken place in Europe and Japan, which effectively was treating coverage as an employee benefit. So when we think of it this way, then there's important implications for thinking about the sources of funds and what the basis for entitlement is. The other point, which sounds technical, but it's really critical in thinking about, again, all people, is that when we're talking about these goals of everyone getting the services they need, that doesn't mean everyone who happens to be in this particular insurance scheme or is covered by this particular program. It means everybody in the society. And so we have many cases of systems that are fragmented, where there's different schemes for different groups, and we need to consider what the effects are for the entire system and the entire population. So those are some details. A simple way of thinking about it in terms of UHC is we're trying to reduce unmet need, both in terms of quantity and quality, and to improve financial protection. So if nothing else comes through, at least hopefully you'll have this understanding that's what we mean by UHC. Now, I wanted to then turn to some of the lessons from experience. And because of time and the nature of this talk, we do in WHO portray these many kind of attributes, or what we're calling here guiding principles of health financing for UHC. I've highlighted the first rather than the others because I'm going to focus in this presentation really on the first one. But just to keep in mind that health financing is about much more than revenue sources, okay? It's really around how the money is raised, but also how the funds are pooled. So the issues around the fragmentation in the system, the capacity to redistribute resources, the policies around benefits, and whenever we're talking about service benefits, the flip side of that is some sort of rationing of those benefits, often with price, but sometimes with the exclusion of certain services and so on. And that we actually have to use the money well. Just throwing more money at a system won't really do the trick. So there's a lot more to health financing that I'm going to talk about today, but so I really want to focus on the first one, maybe in terms of the initial question about how do we find the money for all of this? How can we afford it? So let me come to it. First, that basically what we know from experience very clearly is that more public spending on health, and yes, of course, also more better policies, actually reduces the likelihood that people will either have to not seek needed care, or that if they do, they will face financial hardship. So one of the critical lessons in health financing, may be very simple, is that public spending matters. This is a chart just taking aggregate data when we looked at government spending on health as a share of GDP. On the x-axis, on the y is the coverage of essential health services using the service coverage index developed for monitoring SDGs. And as you can see, there's a lot of variation across countries, but in general, there is this pattern that more public spending, and in fact, when it comes to services, it's really more total spending, in fact, leads to more service use and better service coverage. Again, with variation, but that's what we see. For financial protection, the evidence is very strong that it's public spending in particular that matters. So what we see on the x-axis is public spending on health as a share of GDP. The different colors are just the different WHO regions, and the size of the bubbles really is about the population size of the countries. But just to basically say that, the GDP of the countries, I'm sorry. So on the x-axis is on the y, the vertical axis, is the dependence of systems on out-of-pocket spending, which I use the acronym OOPS for out-of-pocket spending, both because in general it's a mistake and it also happens to refer to out-of-pocket spending. And what we see in general is that the less that governments are able to spend on health, the more their health systems are funded directly from patients. And that raises real concerns about access and risk of financial hardship. So the message is kind of simple and clear from experience that countries need to rely on more public spending, for sure, and a predominant reliance on public spending to fund their health systems in order to really sustain progress towards UHC. The problem we have, and when we think about the context with COVID-19, there's the health impact, but really there's going to be a prolonged fiscal impact. Because right now we're having, in a sense, what might be called an expenditure shock, which is governments are quite rightly responding to the high needs by spending more, both for health, but also for social protection, for employment, for income support, and so on. So a whole range of spending is taking place while the economies are really, growth is falling or has gone negative in many countries, and public revenues in particular are falling, that tax revenues are falling. So we have more expenditures and fewer revenues. And so countries are taking on more debt. Lower and middle income countries maybe will be borrowing more from development assistance or commercial sources, but even high income countries are borrowing from commercial sources and financing their spending through deficits and debt. And so what this means going forward, and not just for 1 year, but potentially for many, is that there's going to be a reduction in fiscal space, the ability of governments to spend on anything, including for health, possibly for an extended period. So it's a real difficult time ahead with this. Now, the question that might be asked after this is to say, well, given this problematic outlook for public finance, what about private financing? Well, again, what we know from experience is that out-of-pocket spending is not a desirable answer because of the implications for financial hardship and, again, the financial barriers to services for those who can't afford to pay. And voluntary prepaid contributions for health insurance, voluntary health insurance or VHI, the evidence, and as well as the theory, in many ways, the failure of private insurance markets is kind of part of the rationale for why there's such a field as health economics, to understand those market dynamics. But basically, it doesn't raise a lot of money in case, and it might actually make things worse. Okay, so this is a chart we have from data from a few years ago. In this picture are the 28 countries in the world where voluntary health insurance or money flowing through voluntary health insurance accounted for more than 10% of health spending. So what you can see is there's not very many countries. It's clearly not a case where richer countries use this more than poorer countries. It's really distributed widely across income groups, across regions, and so on. The overall global average is about 6% of spending flowing through this mechanism, okay? So it's not big. It is big in a few countries. And I think this is really what I want to come to, that where voluntary health insurance is large in financial terms, it may do more harm. This chart shows 5 countries, and basically it shows on the one hand the coverage of the population with private voluntary health insurance in one column, and then in another column the share of health spending, of total health spending that flows through this mechanism. And what we see is, for example, in France, where the private voluntary insurance is explicitly complementary to what the government system funds. So the government social health insurance system covers everybody, and it has high co-payments. And then this voluntary system, the mutuelles, basically cover the co-payments, and together they provide protection. And what you see is high population coverage and relatively small share of spending. And in a sense, those complementary examples, France and Slovenia, you could argue that the voluntary health insurance plays a constructive role in contributing to progress towards universal coverage by providing this extra coverage. In the UK, small population coverage, small expenditure probably is okay, has some inequities involved with it, but doesn't do a lot of harm. My concern is in the bottom part when we look at Kenya and South Africa. And South Africa is the best documented case of this, where nearly half of health spending flows through voluntary health insurance, which only serves about 16% of the population. Here, there's a major concern because basically the people with the voluntary health insurance are higher income. And basically it is skewing overall system resources to serve this relatively small and well-off group. It's not distributing resources to need, but rather in a inequitable way towards income. And why we care about that is, in a sense, going back again to the idea of UHC and whether we're all in this together or all in the same boat. The concern in the context of a country like South Africa and in some other low and middle income countries where it's growing is that where you have scarce human resources, scarce skills and so on in the system, that those health workers tend to move towards where the higher payments will be, right? So this small coverage but high expenditure in the South African context basically moves the health workers to serve the rich minority of the population at the expense of the majority, right? So it's, part of the discussions there and elsewhere is saying, why should government care about these purely private choices? And in that context, I would say less so in a context like the UK, but in this South African context and Southern Africa more generally, some other countries like Brazil and so on, government needs to care about it because that private actions, those choices of individuals and firms actually have spillover consequences for equity and efficiency in the health system as a whole. So in that sense, it is a public policy concern, right? And so again, it goes back to what we care about in terms of UHC. Another important lesson, and something we've been arguing about for years, and COVID has raised this issue more explicitly, is that the traditional ways of what's called social health insurance funding, of relying on employer and employee contributions, really was never a good idea in the sense of UHC when we think about this again as a right rather than just an employee benefit. But we've seen in some countries, in the United States and some other countries, that where coverage is linked to employment and you get a big economic shock that hits employment, it both hurts on the revenue side and people lose their entitlements and benefits. So it's really actually a concern when we treat health coverage as just an employee benefit rather than something that's universally available to the population. This is just an example from Kenya where they've seen as a consequence of what's happened to people's incomes in relation to COVID, that there's really been a big drop in the contributions to the National Hospital Insurance Fund, Okay, so it is a real concern when you have this link between employment and health coverage. Now, in some countries, France is one, there's been many others, in Japan as well, where you have this systems that used to have very strong links between employment and health coverage have progressively delinked that and broadened the tax base away just from wages. And instead towards, in the French case, they call it a generalized social contribution and so on, coming more from income and not just from the labor market. And again, it's really critical because part of the concern of governments, their important concern is to maintain or ideally increase employment. And when we effectively make health coverage a tax on employment, it may be highly problematic. So it is possible to maintain your health insurance arrangements, but move away from the employment and wage link. And I think that's one of the important messages, and becomes more important for systems to be resilient to shocks, such as what's happened with COVID. Okay, so for the last part of my talk, I really want to point a little bit towards 2030, and in our new context, what really might be, what do we want as kind of the future of financing for UHC? As a good economist, I have to start with the bad news. I hope I'm a good economist, so at least starting with the bad news, that as we know, the tough times are already here, in fact. Living, obviously, with the health and health system consequences of COVID, but again, also the macro fiscal things, lower growth, possibly negative growth, fiscal shock that's even greater than the growth shock, I think. So there'll be more need for services, especially as people start to return to services, more debt that countries will be taking on, less public money available and so on. And then as I've shown that just because we need alternatives, it doesn't mean that private financing suddenly works, right? So this, is a problem. It can make things worse. I will say more positively that we have past experiences of countries that in difficult times, and we think of Thailand in particular, when they introduced their major coverage expansion in the early 2000s, it was in the wake of the Asian financial crisis. So it was an opportunity for them to actually expand coverage by making significant changes in how their systems operate. So I'm going to suggest here some directions for change that hopefully can mitigate some of these problems and actually lead to some improvements. And really it's 5 points. One, which I think you spoke a bit yesterday, and I'll come to in a second, is really about the agenda around public health and preparedness. Second, around efficiency. Third, equity. A discussion of innovation, because everyone seems to love innovation, and I'm a skeptic on that. And then something I'm calling easing of the revenue situation. So first is this: when we define UHC and say that everyone gets the services they need, for us, technically, we're saying not just personal health services, but population-based services. And we may have said that in some presentations and discussions, but in practice, it has been neglected. And it's been a critical neglect. And yesterday, one of the messages I heard about was that we have to break this cycle of neglect of preparedness, because the consequences really have been severe for lives and for livelihoods, and so, there's just an important agenda here to deal with. And we need to kind of say that what we're calling step 0 for UHC is what we call common goods for health, which are really the kinds of population-based functions and actions that require collective funding, that require a political decision to fund them. And they break down really into these categories of things. I'm not going to go into the details of this because I think probably everybody listening in knows a lot more about the health dimensions of this than I do. I'm just suggesting that we need to reprioritize on these functions and ensure that they're put on a population-wide basis, okay? So we have in them things around policy and things like health taxes and regulations and so on. What is important, though, is not just on the what we need to spend on, but how we approach the issues. And the critical point of this figure, that I'm showing here is that what we can't afford, what no country can afford, is to have one approach for health security, for preparedness, and a whole separate system to try and move towards UHC. Health system strengthening is the key to both. A lot of the work of health workers, of health facilities, the work on disease surveillance, that kind of comes out of health facilities and systems, and the idea that we would have a whole program of work that's just health security and another program that's just UHC without bringing that together, that's highly problematic and not sustainable. So this is really, I think, the key is HSS for health security and UHC. Even though a lot of the agenda goes beyond health system strengthening as well, there's also a multi-sectoral dimension, but we cannot approach it in a vertical way. Now, we have done work on this on an agenda we call cross-programmatic efficiency. And many of us have talked and complained in a way about the fact that health systems, and people have complained about WHO also being organized as silos and so on, and we need a health systems approach. What we're trying to do is go beyond talk on this and to say, okay, we need to identify how they waste resources because we're duplicating things. If we have one surveillance system for each disease, they might work well independently, but when you look across them, when you look system-wide, there's a lot of duplication and overlap. It also is not just wasteful, it can impede care coordination, most fundamentally because if we're talking about a people-centered approach rather than a disease-centered approach, we recognize that one person may have comorbidities and so on, and if we organize systems by disease, we're going to not have good coordination of care. And critically, because the health threats themselves are interconnected, as we're seeing with NCDs and COVID, for example. So we need to have this system-wide approach. It means not doing business as usual. I think a big part of the advocacy agenda, and many of, I think, and for patient groups as well, many of which are organized around particular diseases and conditions, is that we need to kind of think, how do we come together around these issues? The fact that we want to advocate for the treatment of specific diseases should be different than saying our disease needs its own separate information system and its own separate procurement arrangements. Systems need to be accountable for delivering results, but they can't continue to run in all of these silos. So, and it's also when we come to those common goods for health, we need to put those functions on a system-wide basis and not organize disease by disease. So that's, I think, part of what and how to spend and the efficiency agenda. Now, in terms of equity, I think it's really important that we design systems to protect the vulnerable. And I think that is, as you know, is part of Dr. Tedros's campaign about protecting the vulnerable and so on. We have in our work in health financing in the context of COVID, WHO has made a strong recommendation that user fees should be just suspended during the outbreak, right? Because we don't want the possible need for people to worry about what it is they have to pay to be a factor, especially in a communicable disease context where one person's choice affects many other people, right? So that's true. The concern, I think, as this goes on is the reality of how long countries will be able to maintain and sustain that approach. We would love for them to be able to do that for a long period of time, but the fiscal realities may be different. And so what we've seen from our experience is that even if the undesirable choice of reintroducing some fees is put in place, there are still worse and less worse ways of doing that. And in particular, it's possible to think about how to prioritize protection of the poor, how to prioritize the fact that you want to put limits on what people would have to pay, and in particular, not just let people be forced to pay some percentage of a charge, which may have no limit on it, and really itself is a barrier to access. So I think there's still ways we can think about how to do that better than how it's done now. Innovation, my favorite subject. And I think what we've seen in the context of COVID is a lot of positive innovation in service delivery, a lot of the work around teleconsultation, for example. The key is we want those innovations in delivery to serve the whole population. And the worst thing you can do in financing in relation to that is come up with a complex array of innovative mechanisms with different rules around entitlement and so on. We have an expression at the end of our health financing course, which is to say that we need to make service delivery more interesting and health financing more boring. You know, and so my job is to be as boring as possible in our work. We need to really redirect the innovation agenda away from financing. There's all this talk about innovative financing, and that might have a role, I think, at international level. At domestic financing level, it's a recipe for fragmentation. And it also is very poorly defined, right? So we want to have actually simple financing to enable innovative delivery, to enable systems to tailor their services to people with different needs, to geographic areas of different contexts and so on. The best way to do that from the financing side is to provide budgets with flexible spending rules, ensuring accountability for that spending, and then let the service providers take care of what they need to take care of and not let lots of financial complexity get in the way. My third point is maybe an unfair statement, but I do think when you hear a lot about the wonders of innovative financing, it is worth remembering that the world is kind of suffering the effects now for 10 years, I think, of what financial innovation has brought us. And so we do need to be a bit cautious about that term. So I do hope by the year 2030 that we won't be hearing much at all about innovative financing, at least again within domestic systems, but that we will see locally tailored, interesting and adaptive service delivery approaches. Whether someone chooses to call them innovative or not, I really don't care. What I care about is whether or not they work. And that's what I think we should care about. And then finally, on the revenue side, we do have this whole debt crisis that is potentially mounting. And if there's an agreement that public finance is critical, then we really need to start looking at an agenda, I think, especially at the international level, around debt relief and debt restructuring. Perhaps that can be tied to certain key actions, especially around preparedness, right? And organizing systems in a less siloed way, both the international and national systems. There's a critical agenda that was already there about improving tax and revenue policy. That was the Addis Ababa Action Agenda. And there's also an agenda around using fiscal instruments in a pro-health way, whether that is about cutting fuel subsidies or whether it's about increasing tobacco taxes or alcohol, sugar-sweetened beverage, and so forth. We want to be sure, and I want to be really clear, that raising money is not the main objective of those measures. The main objective of those measures is improving health. If they also raise some public money, as they might, that's good. That money will not necessarily just flow to the health sector, but that's okay. There's a lot of needs that governments have in that regard. But that's also, I think, part of the agenda that we need to promote going forward. So the last thing I want to say is that I focused mostly on these technical issues and directions, but ultimately it comes back to, you know, I think the expression around the SDGs is the world we want, right? So that it is coming back to a question of values, okay? So we need to decide, and I think society by society, because it is truly under threat, I think, as most of you know. Are we all in the same boat? What does we mean, actually? Are we committed to serve the vulnerable? And when we talk about sustainability, let's be clear on what it is we want to sustain, right? If we want to sustain systems that reduce the gap between the need for services and the use of services, that improve quality, that protect people, all people, against financial hardship, and that are prepared to prevent or respond to health emergencies, then there are certain implications for how we move forward. This really needs your voice and influence. And after we do that, then we can talk about what I love to talk about, which are all the joys of health financing. So thanks very much. If you want to have more on health financing from us, you can visit our website. So thanks again.
Thank you, Joe. Thank you very much. And you rightfully said in the beginning that you left us with more questions probably than answers. And we have received many questions. We will be taking them forward to be answered in writing. Due to time, we have to limit the Q&A session. However, Joe, knowing that you are leading the health financing team in Geneva at the WHO, it is really reassuring that all 194 countries, member states, will get the right advice on how we go through this crisis and how we make our systems more resilient and how they recover. Thank you very much. Kavaldeep, over to you.
Thank you very much, Joe, and thank you, Nada. I can take the message that, yes, it's going to hurt my pocket in taxes, but I am happy to pay those taxes, I think. Joe, thank you. You reassured me. I do need to increase my tax payments. And thank you for laying this out clearly and neatly that patients should engage in this issue. And we will call upon your services again and again, I think, because what you have given us is a roadmap. And I have a feeling that we'll be referring to it over the next 10 years, as you have said. It's not short term. And we will always say that we first heard it from Joe at our Global Patients Congress, and we knew what was coming. And we don't want to be sounding like Cassandras. We will guide our health systems and work with them. Thank you, Joe. And now I will ask the audience to please join me in a very important session. The next session is the Patients Shouting Cafe. And it's almost what Joe was doing. It's about patients shouting about the issues they've felt and raised. And it's a great method of advancing health because it allows both the health professional and the carer and the family and the society to hear what patients have to say. It's a great methodology of improving healthcare at grassroots levels and at hospital facilities. Please join me at the next session. And thank you very much. And we'll see you on the other side. Thank you.
Joe, thank you.
Thanks.